Hi class, we're back for part 3 of the lecture on chapter 7, childhood language disorders. And we left off with just beginning the discussion on brain injury. When we're talking about brain injury as causative for language disorders in children at this point, we are not referring to those that happen while the developing infant is, or the developing fetus is in utero, or those that happen right at the time of birth. These are injuries that are acquired. Most typically, they're related to things like transportation related accidents or falls, recreational accidents. They can be the result of infection or a disease process. They can be the result of physical or psychological trauma, an abuse, intentional harm to the child, accidental poisonings, etc. If the injury is a mild one, the child will probably show very little lasting effects on the development of their language. However, they would continue to be at elevated risk for things like hyperactivity or psychiatric illnesses. I had a student many years ago now who, as a second grader, showed some pretty significant social pragmatic and behavioral symptoms or manifestations at school. He ended up being diagnosed with childhood anxiety and childhood depressive disorder related to some pretty significant psychological trauma, secondary to his parents both being in and out of prison, in and out of drug rehab, him in and out of the foster system. So we know that those things can have significant impact on the developing child, on the developing cognitive abilities of the child. When we're talking about injury now, we classify those based on closed head injury or open head injury. So closed head injury would be where there is no penetration or opening of the skull. These tend to, although they'll be more diffuse in their symptoms. And the reason for that, we'll talk about this again when we get to adults, is that in a closed head injury, like say it's from a significant fall onto a hard surface, the brain, is suspended in fluid basically. And so in a closed head injury, it's going to tend to, the brain slosh around and hit on the inside of the skull on one side, and then there's going to be a counter movement to the other side. So there may be injury on both sides of the brain. An open head injury tends to be more focal, so focused on one part of the brain where the damage happened. That closed head injury is called contre-coup, where we have injury on one side and then move to the other side. In an acquired brain injury, there will typically be a history of normal language skill development until the time of the incident. And you remember back my story about the student that I saw at Providence, that's exactly what mom claimed, typical development until the time of the accident. And that would be the case if we're going to say this language disorder is a result of the injury. The severity is going to be based on the site of the lesion within the nervous system, within the brain, and the characteristics of the child before the injury occurred. So if this was a child that already had some developmental challenges and then has this accident, it's going to result in a much more severe outcome for this child. Contrary to popular belief, brain injuries in children do have lasting effects, some of which may not manifest until many years later. I have a very good friend whose son, when he was about 2 years old, climbed up on a piece of furniture and fell out of just a first floor window, but fell out onto the ground. He had, at the time, a minor concussion. Everything was resolved. No learning problems through school. Did just fine, and at age 21 developed epilepsy that the neurologist said was likely the result of that original incident when he was 2 years old. So now we're going to move on to the assessment process. So as with any other assessment that we've talked about so far and are likely to talk about ongoing, the first part of this process is referral. In children under 5, This referral is going to come usually from the parent and or pediatrician. In the state of California, and I believe this is true in other states, they just call it something different. If a disorder is present at the time of birth, so cleft palate, cerebral palsy, Down syndrome, some other syndrome that's really noticeable at the time of birth, that referral may come in infancy. It sometimes comes directly to us as clinicians in private practices, or if we work in a hospital setting, especially if you're affiliated with a children's hospital. Sometimes that referral comes through other county agencies, like in California, the regional centers are the ones that get referrals for those really, really young children, and then they send them on to us. They may come from the pediatrician's office to us. So we get referrals from all kinds of sources, but it's generally from the parent or the pediatrician. We looked at normal development back in chapter 2, and for obvious reasons, we have to know that information because we can't determine disability unless we know what is the norm or what is to be expected for different ages. So if there is some deviation or delay from the expected development, then a referral for assessment is warranted. It's appropriate. There's a history that is changing a little of pediatricians, of general practitioners taking a wait and see, especially when there's no known cause. So for the parent who just brings their child to a well child visit and says, well, my little one isn't talking yet and they're 18 months old, or, they're not making sentences. They don't seem to be following directions. The pediatrician may refer for a hearing assessment. That comes back fine. And they say, well, let's wait and see. That is not the right approach at all. And it is changing. What's interesting to note is that in medical school, even people who specialize in pediatrics don't often have very much coursework in speech and language development. And so sometimes they are making that lack of recommendation really from a point of ignorance, not in terms of my calling them ignorant people, but in terms of really not knowing what the appropriate developmental process looks like. But as I said, that is changing. We're seeing more and more and more pediatricians taking the let's go get it checked out before we say wait and see. Once a child enters school, the referral is generally made by other school personnel. It's really kind of unusual for us to get a referral from a parent unless that parent has talked to the teacher and the teacher says they don't have any concerns. Then we might get the referral directly from the parent. But it usually comes from other school personnel, either the teacher or the school nurse, a resource specialist, which is the academic specialist on campus. The book again talks a little bit here about screening, and it again is a process you should know. There is some validity to it, but again, in the schools, it is considered a form of assessment and requires parent consent. And I see this on forums that I'm on all over the country where people don't get parent consent for screening. In the state of California, that will lose you a lawsuit. That may be different in other states, but in California, our courts have ruled that we must have consent to do any form of screening. That would include, for example, if a teacher sends a child to me and says, Mrs. Chambers, can you just listen to little Billy tell you a story and then tell me if you think he needs to have a referral for speech? That's a screening. They're not allowed to do that. I am not allowed to single out a child and pay attention specifically to their speech for purposes of determining if they need an assessment. Now, if I happen to be walking across the playground and I hear little Billy lisping, I can then say, hey, I want to see this child for assessment. That's fine, but he can't be singled out to me. Comprehensive evaluation. This is like, I want to say yada, 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 because we've talked about this before and we will talk about it again. The first part of comprehensive evaluation is case history. This is generally a case history and interview, in my mind, all goes together. Now, we can send a case history home for parents to complete, but I still think it's best practice, and it is my practice to always do that in the form of an interview. So we're going to take a developmental history, asking about when the child achieved significant developmental milestones, like when did they start babbling, when did they start, when was their first word, when did they take their first steps, when did they start to combine two words, etc. We're going to ask questions about their general health history, paying specific attention to things like histories of high fevers, hospitalizations, any injuries, any surgeries. So that's also looking at their medical history, any medical conditions currently. Is the child taking any medication? I need to know. Certain medications have impact on things. For example, the insulin. I need to know if a child's diabetic, if they are insulin dependent, because needing a dose of insulin can certainly impact a child's behaviors and participation. So we need to know those things. We like to ask questions and need to ask questions about the size of the family and resources. Now, I'm not going to ask parents their income. That's none of my business. But I ask questions about size of the family and, who's at home that is interacting with the child the most. Are they English speakers, Spanish speakers, Japanese speakers? Doesn't matter to me. I just need to know what the languages are in the home and how that might be impacting the child. I would ask questions about the child's current skills and interests. What are their favorite toys? What do they like to do in their free time? How are their behaviors at home? Do they get along well with family members? Do they get along well with peers in the community? And then I want to ask questions about what the parent's perception of the child's difficulties are. And in some cases, it's also appropriate to ask, well, how does the child think about that? Are they frustrated? Do they show any reaction to their ability to communicate? So that's all part of case history and interview. We are also going to do a comprehensive language analysis, and this is should be a very broad-based assessment, looking at all of those language domains: content, form, and use. And we look at them both receptively and expressively. So what the child has, their ability to respond nonverbally to information we present them by either pointing to pictures or following directions, understanding what's been read to them, for example, and then expressively, how well they can respond with spoken responses or, in some cases, signed responses to our assessments. Our assessments need to be functional. We've talked about this before. We're looking at the extent to which those language skills are impacting their ability to function in the home, at school, in their community environments. So can they get their needs met? Can they request objects or actions? Can they express feelings of interest and pleasure and excitement? Can they respond to questions and requests? Can they make comments? Do they effectively use social language to engage with their peers? Do they participate verbally in the school curriculum? Do they respond to school curriculum? And that's back to our requirement as employees in schools, if that's the setting we're working in, to support children's access to curriculum. So remember back to Halliday's functions back in Chapter 1. We're looking at how children have ability with all of those functions. We also are going to potentially do criterion reference tasks. Now, this is all part of our comprehensive language assessment. Criterion reference tasks look at the child's level of performance on a particular task or skill area against a standard or a criterion. So, for example, this is a made-up example. What percentage of object functions can the child name out of a field of 20? Okay, what I mean by that is if I show the child 20 different pictures of objects. So it's a picture, but I'm holding up. What do we do with this? What do we do with these? Right? What do we do with this? And I'm looking for, can the child say you write with it, you look through them, you make phone calls with them? Can they tell me what the object function is out of a field of 20? And I would have a specific criterion for pass fail for that. Maybe they can give me 18 out of 20 or 17 out of 20, and I say, okay, that's good. I don't use criterion reference tasks often. as I don't find them particularly useful in making a diagnosis. Where I find them very useful and do use them often is in progress monitoring of goals that I'm working on. I also use them with children sometimes if I'm testing out of their age range. So, for example, that I test preschool kids. And sometimes I know that I'm testing maybe a 4-year-old who I know doesn't have good enough language skills to participate on the test that's specific for a 4-year-old. So I may go back to something like showing them picture cards and just saying, what is it? What is it? What is it? Or show me which one cuts, show me which one writes, just to see where their language skills are. So those are criteria and reference tasks. The next is norm reference tasks, and this is probably the biggest part of my formal assessment and most of speech pathology's formal assessment. This is when we're looking at the child's level of language performance against a national sample of same-aged peers. These are commercially produced tests. They are based on significant amounts of research, and if they're good, that research was done across the country and across dialects and includes children from different backgrounds. So we truly are looking at this child's performance in relationship to same-aged peers from a national sample. These are usually big, broad, comprehensive tests, although some of them are very specific to syntax or to vocabulary, but they are norm referenced. Norm means we're comparing the child to the normative sample of same-age peers. The third kind of assessment that should be included in any comprehensive assessment of language is a dynamic assessment. And this is looking at how well this child performs on tasks that we've already identified as a weak area for them when they have some varying level of support. So, for example, I'm going to give you 2 examples of this. I have a child maybe in a special day classroom that we're working on increasing vocabulary and increasing utterance length, who just can't do that by himself. So, but he will fill in the blank of a phrase. So perhaps I will use a starter phrase with him. I see a, and he can see it. This is a child who he's on the autism spectrum, has some reading ability, and he can have this card in front of him that says I see a. So when I hold up a picture and say, what is this? He can look at his starter and say, I see a cup. I see an apple. That would be dynamic assessment. Another one that I use often is one of the tests that is one of my preferred tests has a subtest in which a child has to tell me 2 words that have the same meaning. But here's how it goes. There's nothing written for the child to look at, no pictures. The directions are, I'm going to say a word, and then I'm going to say 4 more words, and then I'll say the first word again. I want you to tell me which one of the 4 words I said means the same thing as the first word. That's a lot for a child to remember. So then I say, okay, the word is grin. The 4 words to choose from are cat, flower, smile, chair. Now, which one means the same thing as grin? Now, that might sound like a really simple task to you, but for a kid, first of all, we're talking a 6, 7, 8, 9-year-old who may have some short-term or working memory problems. That's a really hard task. And the words do get much more difficult. So what I do with that test is I will make a card with just the first word. So I have a card that says grin. And I say, here's your word, it's grin. Now I'm going to say 4 words. I don't have anything else written down for them. Remember, your word is grin. Which one meant the same thing? That makes a huge difference. Now, I can't use their score for that and say that's their actual performance because I've given them a level of support. But I can still put that in my report. It's important information because it shows that the child understands synonyms, which is the goal of the subtest. Do they understand the word relationship of synonyms? Yes, they do. Did they have some short-term memory problem impacting their ability to perform? Yes, they did. The problem is memory. It's not synonyms. It's not language. So those are the reasons we do dynamic assessment. It also gives us a really good place to start writing goals from. We can talk about that another time. As part of the comprehensive assessment, we also want to do observational measures. And this is looking at the child's language across all of those domains, content, form, and use, in naturalistic activities with their peers, sometimes with their parents. So, in a school setting, I go into a classroom and I observe the child participating in the classroom during the instructional day or part of the instructional day. I always ask the teacher, when is a time when the child is going to be most interactive within the classroom setting, responding to questions or participating in a small group. And that's when I go in and observe. I go out on the playground and observe the child interacting with their peers. I'm listening for, do they initiate interaction? Do they have a give and take of conversation with their peers? Are they able to give direction and follow direction? Those sort of things. In the setting that I'm working in presently, when we are meeting in person before COVID, we would often go into the child's preschool room. Even if they were out in the community, we would get permission from the parents to go to the Montessori school or wherever the child was, sometimes in the home. Often in the home, we will go and observe the child to see them in their natural environment doing their natural activities. So those are observational measures. And then in the school setting, we also will do curriculum-based assessment. And now we may not be doing this on our own, but we'll be looking at the results of someone else's assessment. We could be doing this on our own, but not often. And this is how well are they responding to the language demands of the curriculum, and is there an academic impact? We always want to look at evaluation of collateral areas. So if language is our concern, we need to know something about this child's cognitive abilities. The book says cognitive abilities should be screened. Okay, I'm okay with that. If we're working in a private setting, and you have the ability and the training to do cognitive screening, go for it. In the public schools, our school program psychologist does the cognitive assessment. They may choose to do screening, but that is their choice. Most often they choose to do a full cognitive assessment. We will do the screening of oral, motor, and structure and function, even if we're doing a language assessment. We will do screening of articulation abilities, even if our concern is language. And we always, 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 if we were sitting in the room with each other, I would make you repeat that word back to me, always do a hearing assessment as part of our assessment. We have to rule out hearing loss. In looking at diagnosis, we are going to look at all of that big comprehensive assessment that we've done. We're going to diagnose. We're going to designate this as a primary or secondary disorder. In other words, if I know this child has autism, I'm going to say they have a language disorder secondary to autism. If I know they have Down syndrome or Rett syndrome, I'm going to say language disorder secondary to. It's a secondary disorder. If there is no evidence of any causal disorder, then we say this is a primary disorder. We're going to say in our diagnostic statement what domains are impacted, content, form, or use. Sometimes we'll get even more specifically. Is it semantics? Is it syntax? And then is it in the area of comprehension, expression, or both? And we'll make some severity statement. Again, mild, moderate, severe to profound. And again, the book is going to tell you we'll make a prognostic statement. And I explained that one other time, that it's not the same kind of prognostic statement like this will be cured or this won't be cured, or this will take 3 months or this will take 4 years. It's more based on that severity and all of the factors saying we need to work on this for a prescribed amount of time, and this is what we expect will come of our work in that time. Couple other terms that you need to know: false positive and false negative. They're very important. We would use the term false positive to describe when a child does not have a disorder but is diagnosed as having one. That's a false positive. Why do false positives happen? Well, they happen because of things like poorly constructed or poorly administered tests, tests that are biased in cultural or linguistic factors. So here's my big plug for that whole cultural issue again. If a test has no children who have a primary language other than English in the normative sample, don't use that test for a child who has a primary language other than English. It's not going to be valid, but I see it all the time. Um, we could get false positive because of poor performance due to outside influences. Things like the child is really sick that day, they're really tired that day, they're very shy, they have ADD, and I'll tell you a couple stories about that. I had a student a few years ago whose both parents worked for a company that did things like it was a cleaning company that cleaned banks and cleaned businesses, and so they worked overnight because that was when that cleaning needed to happen. They had no childcare, so their children came with them to work and slept on the sofas and the chairs in the banks and in the businesses they were in, and then they'd get waken up and put back in the car and move on to the next business. We kind of need to know those things when we're testing kids. I had another student who I was doing his triennial assessment, his 3-year review assessment. Now, he was a really shy, quiet kid anyway, pretty introverted. He was in 5th grade at this point. I really thought I was ready to dismiss him. He'd made really good progress, but he was very shy, very quiet. So he came in the day of the testing and did not do well at all. And I was kind of stunned because I really thought he'd made such great progress. So I happened to be talking to someone else at school the next day, my psychologist, or someone that I can talk to about the child's results. And they said, well, his mom just died. I had no idea. No one had thought that that was important information to give me. His mom had literally died like 2 days before I brought him in to test him. So I didn't even know his mom had been sick. And so what I did was he lived with grandma, when grandma came in to go over the test results, and I was explaining to her, I said, you know what? I was thinking he was ready to dismiss, but we're not going to dismiss him, but not because of these poor test results. I'm going to not dismiss him because he doesn't need any more change in his life. The test results don't support my dismissing him, but I don't think they're valid. But I just think he needs a continuation of what is stable for him, and that was stable for him, coming to me twice a week with his small group. I said, and we're going to test him again next year. And sure enough, the next year when we tested him, he was ready to be dismissed and went on to 7th grade with no goals, no language goals at least. So we need to know if there are outside influences impacting a child's performance. Otherwise, we get false positives. Children that receive a label that is untrue may follow them through school, and that's really problematic. They may be stigmatized. The teacher may have lower expectations for that child than they should have, and they're going to be receiving very expensive and very time-consuming services that they don't really need. So we need to work really hard to make sure our assessments are valid. So let's talk about the other side of that, false negatives. A child who has a language disorder but is not accurately identified. Why does that happen? Almost the exact same reasons. The implications of this are that they are not receiving services that they need and are entitled to under federal law. And now they are also going to have some limitations in their ability to access school curriculum and to demonstrate progress. So we need to work really hard to make sure our assessments are comprehensive and that they are valid for that child. Again, I'm going to talk about children with language differences because that is a different conversation. We should not identify a child as disordered simply because they have a different language other than English that's impacting their learning in English. We have to do better to provide quality assessments for those kids. If they are not disordered, however, and we work in a public school setting, our expertise can certainly be a valuable asset support for a classroom teacher. Our title actually in public schools is as a support person. And that means we support academics across the board, even for kids who are not on our caseload. We do have the expertise in language development. And so we can be an asset to that classroom teacher for how to best support that child's classroom participation and their language development. But we certainly should not call this child disordered in any way. Um, Children who are dual language learners, so have two languages, sometimes more than two, they have a couple different titles that go along with that. Some children are simultaneous bilinguals. I'm sure some of you sitting here listening to me were simultaneous bilinguals. These are children from birth to age 5 who are learning two languages at the same time. They have two languages in their home all the time, and good examples of those languages. So fluent speakers of both languages, simultaneous bilinguals. Then there are sequential bilinguals. These are children from 5 years of age and over, typically, is what we're talking about, who have a primary language and then come to school and begin to learn English as their second language, if we're talking about services here in the United States. It is a true second language. There is a big developmental difference between those two things. A simultaneous bilingual is learning those two languages within the same developmental order we would expect any child to learn language. A sequential bilingual is going to learn that second language in a very different developmental process than a monolingual learner. In the schools, the kids who are second language learners or dual language learners are referred to as English language learners because we live in the United States. And again, they may seem like they have some weakness or disability, but they're not. They're just going through the normal process of learning two languages. So learning two or more languages, either simultaneously or sequentially, should have zero impact on the child's ability to acquire language. And they are very overrepresented on special education roles because of flawed assessment practices. Okay, I'm going to stop this video and we will continue the rest of this in Zoom. Please bring your questions so that we can talk about that. And in our last video, I recall saying, I'll tell you more about that in our Zoom, and I don't remember what it was. It was about autism, but I don't remember specifically. So if you do, please bring that question to me in our meeting. All right, see you later.